The next speaker and the last speaker of this session is Dr. Abdul Jabbar. He is the professor of medicine and endocrinology, currently serving in Dubai at Medcare Center. Sir is the former and visiting consultant in Aga Khan University Hospital, Karachi as well. Sir, please join us, and sir will be delivering talk on the medullary thyroid carcinoma.
Assalamu alaikum. Last but not the least, the topic given to me is not medullary thyroid carcinoma. It is only navigating the occult metastasis in a case with medullary thyroid carcinoma. So you have heard 2 sessions about thyroid. The one by Imran was very good about the thyroid nodules, but that was low risk. But to give the message, all medullary thyroid carcinomas are high risk. And that's why the important message, thyroid carcinoma, especially medullary one, is the first to give us insights into the germline mutations, which can lead to cancers, which you can diagnose much early, even in the first 2 years of life. So this is a very different topic and a difficult one. But as I see here, it's very uncommon compared to papillary and follicular thyroid carcinoma. It used to be reported as 1 to 2%, but as reported by my colleague here, because of the increased diagnosis of papillary and follicular because of the imaging techniques now, the percentage of medullary thyroid carcinoma is going down. So all patients with MEN2A, MEN2B, familial medullary thyroid carcinoma, they have red germline, but approximately 50% of the sporadic, in which there is no family history, there is no mutation in the family, still 50% have got somatic red mutations as well. So we have to be careful. Now the phenotype on the clinical characteristics depend on the genotype as well and the phenotype. But as you can note here, in the sporadic medullary thyroid carcinoma, which usually occurs between 4th and 6th decade, who present with a palpable thyroid nodule, about 70% of the patients have cervical metastasis already. And 10% of the patients have distant metastasis as well. This is at the time of diagnosis. The prognosis is already dependent on the patient age and male sex, but the presence of local tumor invasion, regional lymph node metastasis, and distant metastasis. So the important question comes in mind, as opposed to the papillary thyroid carcinoma. We heard the 2 cases before. You find it, you diagnose it, you remove it, you are relaxed, and you've got a tumor marker available as well. In the cases of the hereditary one, now for the MEN2A, they've got 2 different categories associated with cutaneous lichen amyloidosis or Hirschsprung's disease. MEN2B, which accounts for the 5% of hereditary carcinomas, as we know, they can develop pheochromocytoma, hyperparathyroidism, and recognizable phenotype. These are the 2015 guidelines which have touched upon that, and like most of you, I don't have an extensive experience of managing medullary thyroid carcinoma. What I'm going to share with you is what is the guideline saying, and there are some of the repercussions coming from the guidelines which need to be addressed when you are managing these patients. So this is a difficult one, but the simplistic approach, whenever you find a thyroid nodule, the first question is, do we do calcitonin always? No. I always question why not. Calcitonin is not very expensive, but it gives you a good insight. But anyhow, I don't do it, you don't do it, because it's not in the guidelines. So we look, there's some guys, but it's not in the guidelines still. They do it. In their guideline also not the European, but they do it. That's why I'm asking how many of you do it. So when I was not, before I prepared this, I was thinking now I should start doing it. So you find that ultrasound neck, and then as usual, as per the current guidelines, most of us are doing it. You don't do the calcitonin or carcinoembryonic antibody. You wait for the FNA report to come back. And the FNA report come back and it says medullary thyroid carcinoma. What is the next step? The next step is, because it's medullary thyroid carcinoma, even if it is familiar or not, you have to look for pheo and hyperparathyroidism if it is there. So first you will take care of those things, at least pheo you would like to take care before you go for the thyroid medullary. So this is what it is saying, the guidelines. The next step is RET mutation. And I don't know here how many of you are able to do the RET mutation. You do cases? Right. So the RET mutation is the decisive factors in many of the centers, depending on that. So that's where I am touching upon that. Evaluate for the FEO, evaluate for hyperparathyroidism, and evaluate for RET. If FEO is present, you should go for unilateral or bilateral adrenalectomy before going for thyroidectomy. If hyperparathyroidism is there and you have established it, when you're going for the medullary thyroid surgery, you will take care with the same thing. If RET mutation is present, you should look for post-operatively with the calcitonin level less than 500 or above 500. And if it is less than 500, you can do the total thyroidectomy, do the cervical lymph nodes if they are available on the ultrasound and follow it up. If it is more than 500, then the important question comes. And the important question is, you diagnose the medullary thyroid carcinoma by the ultrasound, and you have looked into the neck very well. But the RET mutation is there, and the calcitonin level is above 500, then as I showed in the previous slide, there is a good chance that the metastases are already there. So you cannot close the case unless you find out where are the metastases. And that becomes the next difficult thing, which according to the region of the world, it's difficult to take care of it. So simplifying it, suspicious thyroid nodule with patient with elevated calcitonin level, thyroid ultrasound, FNA, PET-CT if calcitonin is more than 100. The standard 2015 guidelines are talking about a level of 500 plus. And these are the new corroboration coming, not fitted into the guidelines, yes, that if calcitonin is more than 500, do the PET-CT. Do the surgery. If normal calcitonin level, routine follow-up and routine calcitonin levels every 6 months or so to find out if the metastases are coming or patient is in remission. If the elevated calcitonin level is there, then comes the metastatic workup. That's where the occult metastases come. And depending on where you are, in most centers nowadays, the nuclear imaging available with the FDG, DOPA, FDG, PT, and all these things depend on that. And because these nuclear scans are able to find a very tiny metastasis as well, as opposed to the ones which we are used to that. So as I showed here, and this is a better representation, 17% have distant metastasis at the time of diagnosis. But what we do at the time of diagnosis, we do ultrasound or maybe CT scan of the neck, do the surgery, and leave it. We may search for it or not, and these are the new things coming up, yet to be, because 2015 was the guideline, they have not updated it so much. And the things have changed a lot now. So if you can identify a metastasis earlier on and you can manage them, because these are in general aggressive tumors, as opposed to the papillary and follicular thyroid carcinoma, where you're doing the thyroid surgery and the metastases are not in the lymph nodes and usually nowhere, it's very unlikely, not impossible, that the distant metastasis will be present. But in the medullary thyroid carcinoma, there is a strong possibility. So 17% have, at the time of diagnosis, 38% have distant metastasis in the post-op surveillance. And 56% of the patients with distant metastasis will die within 5 years of presentation. So something to keep in mind when managing these patients. These are the ultrasound and even ultrasonic features in the expert hands can give you some insight about that the nodules are not different very much from the usual ultrasound thyroid nodules, but there are some of the features which will mention you that the M type with aggressive US ultrasound features and B type without aggressive. So if it is aggressive type, you have to go for occult metastasis identification if possible. The tumor marker of calcitonin and carcinoembryonic antigen is very useful in terms of deciding how far to investigate. So this is the new thing in the pre-op imaging. Patients with a pre-op calcitonin level of more than 100 picograms per ml might benefit from the comprehensive imaging. And this is both 18F FD DOPA and FDG PET CT scanning. I was not sure which centers in Pakistan can do that. Okay. So because I was not aware of that, and in our UAE where I am there also, except for 2 centers, the other centers don't have it. So I called Masih Zama, our nuclear physician. He said, we can do gallium dotate and PET-CT, but we don't have these ones available in these cases. Anyhow, if you suspect it based on the calcitonin levels, still not bad, because there are so many other modalities available which will not be able to identify the small tiny ones, micrometastasis, but the reasonable size could be identified on the usual scanning. So the post-op imaging is decided by follow-up in 2 to 3 months to obtain a new baseline calcitonin and CEA levels. Then you keep a level and keep repeating it, because the doubling time is also important in terms of the aggressiveness of the tumor and what to do for. Undetectable calcitonin levels post-operatively, annual measurements of these 2 things, and it's done. And elevated post-operative calcitonin levels, like thyroglobulin in the other ones, you have to look for it, should be considered as a metastatic disease of unknown location and should prompt comprehensive imaging. So it's easy in the papillary ones because you can do the radioiodine thyroid uptake, but here the facilities are not available in most centers, so we are stuck and we have to go for the usual modalities available. So we have got the usual one, ultrasound, CT scan, MRI. These special ones, F18 DOPA, which is the best one recommended for the medullary thyroid, F18, FDG, and 68 gallium DOTA. So ultrasound of the neck is the most accurate. If you find it and the local metastases are there, it should have been taken care at the time of primary surgery. Pulmonary metastases occur in 33 to 54% of the patients, typically numerous and may be associated with mediastinal lymph nodes. They usually is a micronodular pattern, and that's the point, because you may do a CT scan and the micronodular pattern may be missed in this setting. If the calcitonin is high, you have to look for that. The classical cannonball pattern is less typical nowadays, but it is possible. Hepatic metastasis, you can go for the MRI, and the various varieties of the MRI now available can show you a good lesions in terms of the hepatic metastasis, so that one can base the future treatment on the metastasis being present. The bone metastasis again present in up to 90 to 54% of the patient. Multifocal, spine and pelvis, 50% have skeletal events related, and the majority affect the spine and the extremities. Radiological appearances are not specific. They may be osteolytic, osteoblastic, and mixed. So MRI in general is good because of the newer modalities available with the MRI. So if you do the diffusion weighted imaging or dynamic contrast imaging, you'll be able to find out, and it can be integrated with PET-MR hybrid. So this is the guidelines of 500 calcitonin level cutoff came from the previous studies, but thereafter it has been recognized now with the new data, and it needs the guideline to be updated, that only 81% of the patients with pre-op calcitonin between 100 and 200 and 200, 500 after surgery had a normal post-operative. So about 19% still had somewhere metastasis present because it was giving the calcitonin level and it was not above 500. It was 100 to 200 or 200 to 500. So even that doesn't show that the disease has been in remission and you don't have to look for other metastases. Patients with preoperative calcitonin levels might benefit from comprehensive imaging just before or even after, rather than waiting for 2 to 3 months and checking the calcitonin level later on. But that's the thing, because these nuclear medicine scans are easy to perform and they can detect the micrometastasis as well. So FDG, PET-CT, and FDOPA proved superior to the conventional imaging procedures in detecting metastasis in patients with medullary thyroid carcinoma. FDOPA had a higher sensitivity compared to PET-CT and seemed more important in assessing the extent of disease. Survival was significantly lower in the FDG PET positive patients compared to negative patients, although the other modalities of imaging was found to be negative. So although the same was true for FDOPA positive patients compared to those with negative. These imaging techniques with PET are expensive, and selection criteria and a medico-economic evaluation is needed, because everywhere in the world it's not easy to go for that. So in terms of the F18 FDG, It shows a low level of glucose metabolism, so you see the expression resulting in low avidity. So these are not hot spots, they are low avidity, and compared with those in the other cancer type. Small size metastasis can present with a miliary pattern, lowering 18F FDTT, and best of the patients with more aggressive differentiation tumor can find it. So the detection rate with the PET-CT was 59%. It increased when the calcitonin level was high. Embryonic antigen was high. CDDT doubling time of the calcitonin more than 12 months, or doubling time of CA more than 24 months. F-DOPA is for well-differentiated medullary thyroid carcinoma. It is the single best modality for the whole body MTC metastasis. 18F-DOPA can detect small in size metastatic lymph nodes as well, which are maybe missed even on the ultrasound and CT scan. And F-DOPA can identify metastasis in unusual locations because it's a whole body scan rather than you're focusing on the certain areas. In the poorly differentiated, F-DOPA is not very useful. You have to go for FDG because it is more able to pick the lesions in the dedifferentiated lesions. So F-DOPA is the number one tracer for the medullary thyroid carcinoma. The detection rate was 66% and 71% per patient per lesion, especially with the other numbers which I have given. The lowest calcitonin level observed in 18 F-DOPA patients positive was with proved lymph node metastasis was 66.7. So it was much below 100 as opposed to 500, which is coming from the guidelines. So just to add up that available, as I checked with Masi, and then I found maybe this is available here. He said it's available in Kiran and AKU probably, co-data. So it's a variety of tracer available. It's taken up in different MTC cells, differentiated one. It is easier to produce in-house with a 68 gallium generator, widely available, lower sensitivity at the top, but more readily available. So I will stop here. This is the last one. So F-DOPA is still FDA approved for Parkinson's disease, but not for medullary thyroid carcinoma. So the guidelines are going back and forth. Tracer can be produced by any cyclotron facility. It is available and offered in many clinical centers. The cost of production is similar to FDG. So some professional societies recommend using PET tracers without FDA approval, like pheochromocytoma and paraganglioma, the Endocrine Society clinical practice. F-DOPA recommended as a part of decisional algorithm for the functional imaging in patients with proven paraganglioma, and guidelines for the neuroendocrine tumors, use of gallium DOTA, while FDA approved this tracer only in 2018, and it still has the little availability in the USA. So revised American Thyroid Association guidelines need something into that you should have the calcitonin cutoff of 150 or 500 is not representative, because even with a basal level of less than 150 following thyroidectomy, persistent or recurrent disease is almost always found in the lymph nodes confined to the neck. Thank you very much.
Thank you so much, Dr. Abdul Jabbar. We can take two questions.
Sir, my question is, can you please elaborate the risk factors of medullary thyroid cancer? As I might be wrong, you said that 50% of the cases are sporadic. Number one. And secondly, are there any association with prescribing GLP-1 and increasing the risk of MTC in those patients?
Sporadic cases are also, the definition of familial cases is, there are two definitions. The strict definition is, in the family there should be 10 cases, which is very difficult. So they revised it, and now they say the less strict definition is, in the family there should be 4 cases. So if the family has 1 case, you will not call it familial, you will call it sporadic, which looks like bizarre. But anyhow, so that's where the definition. But the other thing is, even in the sporadic cases, when you go for the red germline mutation lookup, you will find them in 50% of the cases which are sporadic. So they were sporadic, the red gene positive means it is something coming from the family. So it's not sporadic. In general, the familial is more aggressive, multicentric, and quickly metastatic as opposed to the sporadic one. There is a third type which is called familial medullary thyroid carcinoma, which runs in the families, but it's not part of the MEN syndrome, etc. It is in between in terms of the aggressiveness. About the GLP-1, there is data up and down over the years which we are hearing it. So the GLP-1 per se has been shown, which they have withdrawn in some extent now, that in animals it showed that it can induce C-cell hyperplasia, not tumor. So that's the reason of giving the black box warning. So if somebody has a family history, don't give it to them. But whether it causes it or not, we don't know. It's probably so far as I understand, the literature is saying if somebody is already at risk, so he has got C-cell hyperplasia or has got family history, and that's what the pharma industry does. And if that person develops the cancer, the person will sue the company. It was because of your drug. So they are saying in the black box warning, don't give it. And now if the doctor gives and it happens, who will be blamed? Doctor. So that's how the pharma industry works.
Actually, sir, the reason for asking this question is I have come across many patients who are multinodular with multinodular goiter, and they are very obese. And the thyroid profile is suggestive of hypothyroidism. So, in review of that, I was basically asking that question: that should we prescribe GLP-1 to those patients or not?
I personally don't think, as per the guidelines, if you have asked and documented, there is no family history, not which type, no family history of thyroid cancer or thyroid surgery. That's what I do based on that. If you want to be super strict, check calcitonin level. Right. You have in the record, I checked calcitonin, it was normal.
Thank you, Jabbar, for the presentation on this topic. It's a difficult topic. I have been managing a patient who has probably approached you as well in Dubai, a young lady who had been operated with total thyroidectomy and neck dissection, and she has MEN2A because she has thyroid adrenal nodules as well, which is slightly growing now as well. In terms of looking for the metastatic site, we have done a bit. With whatever is available in terms of imaging, we have done MRI of the liver, we have done bone scan, we have done a CT scan of the chest, we have done PET scan. We have not been able to, and post-operatively, she is running this calcitonin around 300. So, and just following her up and looking at the doubling time of the, see whether it goes up, and intermittently imaging them to look for any structural site of metastasis. Now the second thing in that case is now we are thinking about, because that adrenal nodule is increasing, is to subject that patient for adelectomy of one side. She has bilateral adrenal nodules. We're going to subject them for, so this is, and I think these imaging are complementary to each other. They do not replace one with the other, and the guidelines, if you go back to the previous guidelines, they were talking about conventional imaging. Now they're more talking about functional imaging in terms of looking for this.
I was thinking if anybody asks me a difficult question, I'll refer to Dr. Najam because he's our expert on medullary. But the case he's sharing with me, we are all sharing because the family is known to me, so they share with me all the data. And I say, what is happening to the metanephrines? Because we postponed the surgery for so long.
The metanephrines are increased, but they are not consistently increasing.
Yeah,
they are fluctuating, and I think I would now recommend that she goes for one-sided adelectomy, the size which has grown.
Thank you. Thank you. 2 questions done. Thank you.
I would request the panelists to please conclude in 1 to 2 statements. Ma'am, you have the mic.
Thank you, Professor Jabbar. It was such an enjoyable talk. I mean, I really loved it. And the fact that you raised the practical problem, which we do face when we do our best and can't find anything. And we know that it is there, it is lurking there, the calcitonin is telling you, and nothing is doing. And then that is the kind of situation, especially when you know that is something you can't afford to ignore. So then after that, I think all we have is surveillance and following up and looking. So that is the case for your case also, I think. So would you like to say?
I mean, for all the cases that have been discussed in this, the presentations, Obviously, I would like to congratulate all the three presenters on the comprehensive talk that they have given on different topics. Dr. Sayyid Ali Imran on the low-risk thyroid cancer, when to approach and how to approach, is something that is changing now, and I think he's updated us, and we should be following the low-risk approach, either just following it up or going for lobectomy and going for radioactive iodine in very selected cases. So that's an approach that we have to adopt, and I thank Sayyid Imran for updating us what's happening in this world. Uh, Dr. Zainab has given us about the subclinical hypothyroidism and cardiovascular, and I think that is a field that is still not very clear in terms of when to start treatment, but guidelines do recommend certain things which guide us to when to start treatment. And for Jabbar, I think I've already discussed, so I don't have anything else to add for that.
Excellent presentation by all the presenters. First of all, just like the IDF president said that we have to diagnose. First of all, primary care, they can't cope, Even our intensivist, the physician, sometimes the diagnosis is missed of thyroid cancer, when. Second comment is, these patients need to be followed for lifelong. It's an important question, that how long you are going to monitor. And last thing, just if they say that, well, if your calcitonin level is more than, according to the guideline, more than 400, so go to PET. PET, we all know it's very expensive. CT doesn't know, so it's a big dilemma. That's it.
Thank you so much all.